Coming to neurodegenerative diseases. So these are also part of the cerebral diseases only. So first is Alzheimer's, the classical Alzheimer's. So why I put this photo is, we know that two classical pathological changes which occur in Alzheimer's. One is neurofibrillary tangles and neuritic plaques. Neuritic plaques and neurofibrillary tangles. So these tangles are made up of tau protein. So Alzheimer's disease is basically a tauopathy. In neurology, degenerative diseases usually have some protein which gets accumulated. For example, Alzheimer is called as tauopathy. Here something called as alpha-synuclein. Some diseases like Parkinson's, dementia with Lewy bodies. All these have deposits of Lewy body pathologically. This Lewy body is made up of a protein called as synuclein. So synucleopathies are Parkinson's and dementia with Lewy bodies. Here a protein called TDP4. So TDPopathies. So one disease is amyotrophic lateral sclerosis, which is a motor neuron disease. We'll discuss that later. So about motor neuron diseases. So just remember, neurodegenerative diseases comes under one of some protein deposits, either tauopathy, synucleopathy or TDP4. So Alzheimer is one common dementia. Dementia is characterized by behavioral disturbances, etc. So there may be memory loss, behavior disturbance. It is usually a chronic progressive disease. There will be difficulty in finding ways. So what memory is affected is long-term memory. Okay. Now this dementia, there are a few other differential diagnoses. Like there is something called as frontotemporal dementia. There is dementia with Lewy body. There is corticobasal degeneration. Plus we have the common vascular dementia. So everything has a particular feature. For example, memory loss is the earliest finding in Alzheimer's disease. Frontotemporal dementia. So when something is frontal and temporal, behavioral disturbances will be predominant in frontotemporal dementia. So behavioral disturbances, so memory loss with predominant behavioral disturbances, it could be frontotemporal dementia. Dementia with Lewy body. Remember, Lewy body is a synuclein deposit which is seen in Parkinson's disease. So wherever there is Lewy body, there is Parkinson's symptom. So Parkinson-like tremors features, then visual hallucinations, REM sleep disorders, plus memory loss. We think of dementia with Lewy bodies. Okay, so everything has memory disturbances, but only the associated features will help. Corticobasal degeneration. So cortical means again there is behavioral disturbances. Basal. We discussed basal ganglia always produces abnormal movements. So abnormal movements, behavioral disturbances and memory loss. That will be corticobasal degeneration. So it's a progressive condition. There is no definitive treatment, but we can prevent it. So usually we give cholinesterase inhibitors like donepezil, rivastigmine in Alzheimer's disease. There are some genes associated with Alzheimer's also, for example ApoE, etc. Okay. So this finishes one discussion about Alzheimer's and other dementias. The next neurodegenerative diseases is Parkinson's disease. The term Parkinsonism is different from Parkinson's disease. Parkinsonism is the clinical syndrome which is characterized by a triad or a tetrad. See this tetrad. Bradykinesia, which is slow movement, resting tremor. We are discussing basal ganglia, hyperkinetic and hypokinetic lesions. Like balismus occurs due to problem in the subthalamic nucleus, right? Chorea occurs due to caudate nucleus lesion. Athetosis occurs due to globus pallidus lesion. Likewise, a substantia nigra lesion leads to this tremor. Substantia nigra normally has dopamine. Niger means black, dopamine is black in color. So when dopamine reduces, it leads to resting tremor, rigidity, postural instability and bradykinesia. This tremor is also called as pill rolling tremors. Okay, the classic bradykinesia, resting tremor, rigidity and postural instability. So if these four is present, we can call it as Parkinsonism. Parkinsonism is not equivalent to Parkinson's disease because Parkinson's disease is the most common cause of Parkinsonism. Parkinsonism is specific, Parkinson's disease is a specific clinical syndrome characterized by synuclein or Lewy body deposits. We have Parkinson plus or atypical Parkinson's disease. They are called as Parkinson plus syndromes. So in addition to this classical four, we have some atypical features like there may be autonomic features. There may be eye movement disturbances. Like this, we tell about different types of Parkinson's plus. I'll tell you that also. So the cardinal four motor features of Parkinsonism are bradykinesia, resting tremor, rigidity and postural instability. Also we have micrographia, masked faces, reduced eye blinking because of low dopamine. We have drooling of saliva, soft voice, dysphagia, freezing and falling. This is most common in the late stages. And non-motor features are there. Like there are some mood disturbances, sensory disturbances, anosmia, autonomic disturbances. But everything is present in Parkinson's disease, but in Parkinson's plus some or more. We'll come to that also. This is a pathology. And this is the brain. This is the normal substantia nigra which is black in color, more dopamine. But here the dopamine is reduced. The same thing is picked up in imaging. See, when you see the substantia nigra, it comes like a tail. Right? It comes like a tail. So the normal basal ganglia looks like a swallowtail. Swallow is the name of the bird. But see this diagram, we cannot see that terminal tail. So this is loss of swallowtail. Okay, so loss of swallowtail in MRI is Parkinson's disease. Why swallowtail is lost? Because dopamine is lost from the substantia nigra. Remember dopamine we had discussed somewhere in endocrinology that dopamine inhibits prolactin secretion. Right? Dopamine is a very important neurotransmitter in brain because dopamine inhibits prolactin. Second, dopamine is present in substantia nigra to help with movements. So deficiency of dopamine will lead to Parkinson's disease. Plus dopamine is present in another system in the brain. It helps to maintain mood. So problems with this leads to psychiatric disorders. So dopamine comes in psychiatry, dopamine comes in endocrinology, dopamine comes in neurology also. Okay, so remember dopamine somewhere. So we'll discuss about the Parkinson's disease. So Parkinson's disease is the most common cause of Parkinsonism. So it can come sporadic or genetically. Dementia with Lewy bodies. So we have discussed the triad of memory loss, Parkinsonism, psychiatric disturbance and sleep disturbances. This is dementia with Lewy bodies. So why these two are taken together is these two are synucleinopathies. Synucleinopathies. Whereas atypical Parkinsonism, they are not synucleinopathies. So what are the atypical Parkinson's or Parkinson plus disorders is, again, one thing we had discussed already, corticobasal degeneration. Right? So cortical is behavioral disturbances. It has memory loss, plus basal is again the involuntary movements or Parkinson-like tremors. Frontotemporal dementia also can be taken here. But the two most important Parkinson plus syndromes are multiple system atrophy and progressive supranuclear palsy. Remember the clue, multiple system atrophy is of two types, MSAC and MSAP. It usually has autonomic disturbances. And progressive supranuclear palsy is of two types, Parkinson variant and Richardson variant. PSP usually has eye movement disturbances. That is, they have vertical gaze palsy, they cannot see up. So they cannot see up, they cannot see down. They have high chances that they fall. So Parkinson disease with predominant fall is progressive supranuclear palsy. Now there is something called secondary Parkinsonism, like vascular Parkinsonism. Like vascular dementia, we have vascular Parkinsonism. Some infections are repeated trauma, that is Box's syndrome. There will be memory loss, there will be Parkinson-like features, some toxins can cause. They are drug-induced Parkinsonism. So any drug which is anti-dopaminergic can cause drug-induced Parkinsonism, like psychiatric drugs. So I told when dopamine is more, the mood becomes problematic, psychosis will come. So most psychiatric drugs are antipsychotics. Psychotic drugs are anti-dopaminergic. So they can cause drug-induced Parkinsonism. Usually drug-induced Parkinsonism has more of rigidity than tremors. So how will you prevent drug-induced Parkinsonism? By giving some drugs like biperidine, triexphenidil. These are anticholinergics. Will be discussed in psychiatry. So apart from that, some diseases like Wilson's, Huntington's disease, some storage diseases like NBIA, neurodegeneration with brain iron accumulation. So these are some other diseases which can cause Parkinson-like disease. So mainly multiple system atrophy, progressive supranuclear palsy. We can take corticobasal and dementia with Lewy bodies and frontotemporal dementia also. So this is how you pick up atypical Parkinsonism. It's early gait impairment, that is lack of tremor, lack of motor asymmetry, early falls. We have to think of progressive supranuclear palsy. Presence of psychiatric drugs, think of drug-induced Parkinsonism. Onset prior to age 40, think of Wilson's disease or genetic form of POD. They are called as YOPD, young onset Parkinson's disease. A Parkinson's syndrome with liver disease, think of Wilson's disease. Right? Wilson's disease it's called as hepatolenticular degeneration. The hepato is, it causes cirrhosis. Lenticular is two lens. It causes cataract. The other lens is the lentiform nucleus of the basal ganglia. So this problem causes wing beating tremors. See, early hallucinations and dementia, think of dementia with Lewy bodies. There is impaired vertical gaze, progressive supranuclear palsy. And how will you think of therapeutically? What is the treatment for Parkinson's disease? Dopamine is deficient, so we give dopamine precursor, levodopa. levodopa is the treatment. It is usually combined with another drug called as carbidopa. Carbidopa is peripheral decarboxylase inhibitor. That is, it prevents breakdown of levodopa in the gut. So levodopa and carbidopa are usually given together. That's why it is called as syndopa. We have some other drugs also. And see, on examination, when dementia is first in Parkinson's disease, it's dementia with Lewy bodies. Predominant orthostatic hypotension. Orthostatic hypotension is a autonomic feature. So it is multisystem atrophy P type. Predominant cerebellar signs like ataxia, it is MSAC. Some eye movement disorders like impaired vertical gaze, impaired down gaze with saccades, it is progressive supranuclear palsy. Okay. And essential tremor is a common DD for Parkinson's disease. Parkinson's tremor is asymmetrical. Usually one side is involved more. Whereas essential tremor is usually symmetrical. Okay. So levodopa, carbidopa is the first drug which is given. There are some other drugs also which are given, which I think we will not discuss here. Please remember the names: MAO-B inhibitors, COMT inhibitors. MAO-B and COMT, these are enzymes which break down the dopamine in the end. So when the breakdown is inhibited, it will be helpful. So MAO-B inhibitors will be pramipexole or ropinirole. COMT inhibitors will be entacapone, tolcapone. Okay, we have salicylic, rasagiline. So like that we have many drugs. Finally, one phenomenon occurs in Parkinson's, which is on and off phenomenon. That is, Parkinson's will keep on progressing. So in the initial stage, when we give the drug, there will be a dramatic response. So initially there will be bradykinesia, but on giving the drug, bradykinesia improves. But later on what happens is, the on phase, that is the response phase, will become very, very less. On giving the drug, they will be very symptom free for only 1 hour or 2 hours. But when we give you the drug beyond a particular dose, they will go for dyskinesia. So the bradykinesia will go for dyskinesia. That is called as off phase. So it is a common feature of advanced Parkinson's disease with levodopa treatment. Okay, so now we will discuss head injury. We have finished about neurodegenerative disorders common. Now coming to head injury. Whenever we think of head injury, just remember this coma scale, Glasgow coma scale. It has 3 components. Total score is 15. The score is split as eye opening has maximum score of 4, verbal response has score of 6, and motor response has a score of verbal response has a score of 5, and motor response has a score of 6. So it is remembered as EVM 4, 5, 6. So eye opening, when it is spontaneous, it is 4. Eye opening to speech is 3. Eye opening to stimulation is 2. No eye opening is 1. Verbal response, complete oriented speech is 5. Confused speech is 4. They speak only words is 3. Only sounds is 2. No response is 1. Best motor response, obeying commands is 6. Localizing commands is 5. Flexion is 4. Abnormal flexion is 3. Extension is 2. And no response is 1. In head injury, GCS of the total score of 8 is important. When the GCS is 8 or less than 8, in head injury, it is dangerous. So it means at that time it may need intubation. So sometimes questions may be asked to evaluate the GCS. So now we'll see some images on head injury which are very, very important. So what is this? See, there's a this is a CT brain. There is a biconvex collection outside the brain. This is EDH, extradural hematoma. Contrast with this, see, this is not convex, it is concave. Okay, so the thing is very clear. This is biconvex and very taut, whereas this is biconcave. This is subdural hematoma, acute subdural hematoma. Because what happens in chronic is the same convex, the same concave shape is there, but there will be some resolution, and following resolution sometimes it may bleed again. Okay, so this is resolving or chronic SDH. If you see black color, it is chronic SDH. Now what is this? This may look like a intracerebral hemorrhage, ICH. But see, we discussed earlier in this discussion, hypertensive hemorrhage occurs in 3 places. One is basal ganglia, it may occur in the pons or in the cerebellum. So this is hypertensive bleed. It is occurring in the mid part of the brain, right? This is hypertensive bleed. But this bleeding is occurring outside in a different place. So this is usually trauma. So maybe the impact would have occurred here. So this is traumatic intracerebral hemorrhage. Traumatic intracerebral hemorrhage is also called as contusion. So these images are very important. So SDH, and what is this? This is not convex collection. This is not a concave collection. Here the white color collection is coming in normal places where there is usually clear CSF, right? I'll shade it. So here usually only we'll get black color spaces, but here we are getting collection. See, this is normally ventricle. Here we are getting some bleed. So there is intraventricular hemorrhage, and this is subarachnoid hemorrhage. So we discussed SAH can be traumatic or aneurysmal. Okay. So this finishes some images on head injury. Now we will come to another important disease aspect, which is demyelination. I'll tell you what is demyelination. Demyelination can occur in the CNS. It can occur in the peripheral nervous system. In CNS, we have 2 important diseases of brain demyelination. One is multiple sclerosis, and another one is NMOSD, also called as Devic disease, neuromyelitis optica spectrum disorders. So these are central nervous system demyelinating lesions. In peripheral nervous system, we have a demyelinating lesion, which is GBS, Guillain-Barré syndrome. So what is meant by demyelination? What is the pathogenesis? See, normally this is the nerve, or this is the axon. Axons are covered by a sheath called as myelin. In central nervous system, myelin sheath is formed by oligodendrocytes. So the CNS myelin is by oligodendrocytes. In PNS, the myelin sheath is by Schwann cells. So what is the function of this myelin sheath? This myelin sheath increases the speed of conduction. Myelin sheath increases the speed of nerve conduction. So when there is no myelin, the conduction will go very slowly, cell to cell, like it will go very slowly across the membrane. But when there is a myelin sheath, the conduction will be very fast. Right? So it is called a saltatory conduction. That is jumping of impulses. There is saltatory conduction when myelin is there. When there is no myelin, there is only a slow conduction. So there are some diseases, especially autoimmune diseases or inflammatory diseases, which damage the myelin. In immunology, we have 2 types of cells, B cells and T cells. Usually cell-destroying immunity will be cytotoxic T cells, or T cell mediated immunity, or cell mediated immunity. So cell mediated immunity, in response to some stimulus, will damage the myelin and will cause loss of this myelin sheath. So when there is demyelination, there will be reduced conduction and it will cause some changes. So that is the basis of demyelination disease. So I told you we have two CNS demyelination disease. One is multiple sclerosis, another one is NMO. This demyelination can present with basically any symptom. If demyelination occurs in the cerebrum, we will get seizures or memory loss, etc. If demyelination occurs in the cerebellum, we will get ataxia. If demyelination occurs in the spinal cord, there will be paraparesis. So practically any symptom can occur. Even CVA like presentation can occur. Okay, so in neurology any symptom can occur with demyelination. But how will you differentiate multiple sclerosis? There is a separate criteria for multiple sclerosis. But for a clear understanding, multiple sclerosis is said to occur when we are able to demonstrate dissemination in space and dissemination in time. Dissemination in space and dissemination in time. What is the dissemination in space? That is, demyelination occurs in multiple places. So see the images here. These 4 images were taken from a single person. There is demyelination of the cerebrum. These white spots are the spots of demyelination. There is demyelination in the corpus callosum. There is demyelination in the spinal cord. You can see this whitish color. There is demyelination in some unrelated places. Okay. There is something called as Dawson fingers. Like if the blood vessel comes like this, there will be perivascular demyelination. So Dawson fingers. So in this MRI, there is dissemination in space. That is, demyelination occurs in multiple places. Plus, there should be dissemination in time. Time means the lesions must be of different time. That is, some lesions must be old, some lesions must be new. If you erase and see the color. This and this are very whitish. This one is a bit dull white, which means this one is an old demyelination, these two are new demyelination. So, demyelination should be present in multiple parts of the brain and spinal cord, plus there should be demyelination which is happening over a long time. Right? So, both old lesions and new lesions must be present. I'll show it here also. See, this very bright are the new lesions. This dull white is the old lesion. So there is dissemination in space and time. Whereas you can see this MRI, apart from there is dissemination is there, but there is no dissemination in time. Okay, so this will be neuromyelitis optica. So what is the difference between neuromyelitis optica? There is another criteria for neuromyelitis optica. It is diagnosed when there is a core clinical characteristic, that is, few places are very typical for neuromyelitis optica involvement. One is LETM, longitudinally extending transverse myelitis. Transverse myelitis is involvement of the spinal cord. See, a long area is involved. You saw in multiple sclerosis, only a small area is involved. You can see here a long area is involved. Plus there should be involvement of the area postrema, or there should be optic neuritis or acute myelitis. These 4 are the typical places where neuromyelitis optica occurs. So even if you don't remember this, so optic neuritis, myelitis, area postrema or brainstem, right? Brainstem is very typical for neuromyelitis optica. See, this is brainstem involvement. Even if you don't remember this one, dissemination in space and dissemination in time should occur in multiple sclerosis, whereas dissemination in space with no dissemination of time is neuromyelitis optica. Now, how will you evaluate both? We are evaluating both by CSF. In CSF, multiple sclerosis, we get a finding called as oligoclonal bands. OCB, oligoclonal bands. They are some proteins. In neuromyelitis optica, we see aquaporin 4. Okay. So in neuromyelitis optica, there is dissemination in space alone. In multiple sclerosis, there is dissemination in space and dissemination in time. One important feature of multiple sclerosis is it is relapsing and remitting. That is, it comes and goes. It is not a single time event. It comes and goes. On taking treatment, it may resolve, but it may come again. This relapsing remitting is very, very important clinically. So if a patient develops some neurological syndrome, any symptom which is coming and going again and again, MRI showing this feature, it has to be MS. Whereas this NMOSD is a single time event. Neuromyelitis optica will respond to steroids, whereas multiple sclerosis will not respond to steroids. So these are some demyelination diseases. Why this occurs, demyelination? Due to some autoimmune pathology or some old infection or some autoreactive T cells, right? So we discussed about the pathology of demyelination, CNS demyelination due to multiple sclerosis and due to neuromyelitis optica. So what is this? I told you multiple sclerosis, relapsing, remitting. There is a disease duration, it has relapsed, it comes again, relapsed, comes again. So this is called as RRMS, relapsing, remitting, multiple sclerosis. Even if you don't remember the graph, remember the clinical scenario. The symptoms come and go again and again. This is usually a very good MCQ for exams. Of course, there are other variants like primary progressive multiple sclerosis. That is, the disease keeps on progressing from the initiation. So that is also there. Then there is something called a secondary progressive multiple sclerosis. The disease is initially relapsing and remitting at present, but after some time it starts to progress. Whatever it is, demyelination lasting for a long time or relapsing and remitting, it is invariably multiple sclerosis. How will you test? Oligoclonal bands. How will you treat? Don't use steroids. There are some drugs. There are many drugs like natalizumab, etc. We are not discussing that here. So this is about central nervous system demyelination. What about peripheral nervous system demyelination? The same thing. Myelin is lost. Here I told you the disease is Guillain-Barré syndrome. So why does Guillain-Barré syndrome occur? There is an infection or a diarrheal infection usually caused by Torpherema whippeli. Torpherema whippeli is the organism which causes Whipple's disease. Whipple's disease is one cause of diarrhea, bloody diarrhea. So there is diarrhea in a particular person. For 1 month he will be asymptomatic. After 1 month he develops progressive ascending paralysis. Progressive ascending paralysis. Remember, till now all the diseases which we discussed were about the cerebral diseases only. We had discussed about injury, demyelination, neurodegenerative disease, and we discussed brainstem in the starting of the discussion itself. Now what we have come to is about the peripheral nerve, right? So GBS is actually a peripheral nerve disorder. So there is progressive ascending paralysis. I told you in nerve there will be sensory changes, there will be motor changes, there will be autonomic changes. In neuropathy, all these three will occur together. So when nerve is demyelinated, these changes occur, right? We have progressive ascending paralysis. So this will be the clinical scenario. So there are few subtypes. The commonest subtype of GBS is acute inflammatory demyelinating polyneuropathy. So adults are most seen. The antibody which is formed is anti-GM1 antibody. Try to remember it if you can. It is demyelinating. So what happens? Schwann cells are the peripheral nerve demyelinating cells. So due to autoimmunity, Schwann cells are affected. There is myelin damage and some problem occurs. So how will you diagnose it? Here we have to do CSF analysis. Like in MS and NMO, we do CSF analysis. What finding we get here is lymphocyte protein dissociation. That is, there will be lymphocytes but proteins will be low, because once they present, already a significant amount of damage would have occurred. So lymphocytes will be there, but the protein amount would have started reducing. So increased lymphocytes with low protein, one of the differential diagnosis will be Guillain-Barré syndrome. So cytoprotein dissociation. So how will they present? Initially they present with paraparesis, then it progresses. The cause of death will be respiratory failure here. So it is an ascending paralysis. Remember, in neurology there are few diseases causing ascending paralysis. There are few diseases causing descending paralysis. Example, snake bite causes descending paralysis. Neurotoxic snake bite, that is cobra, causes descending paralysis. Snake bite is a neuromuscular junction disorder. Okay. So there are other variants, that is AMNA, AMAN, acute motor neuropathy, acute motor sensory axonal neuropathy. Try to remember the antibody alone. There is something called as Miller-Fisher syndrome. Okay. Miller-Fisher syndrome involves ophthalmoplegia. So this may be asked as a question. So there is progressive ascending paralysis plus there is ophthalmoplegia. That is, if there is third nerve involvement, we call it as Miller-Fisher syndrome. So I told you how the scenario presents, why the pathology occurs, how will you diagnose it in CSF. So the CSF finding is only a contributory finding. What is the investigation of choice? Yes, by doing a nerve conduction study. What finding will occur in nerve conduction study? I told you the function of myelin is to give speed of conduction. When myelin is not there, there will be slowed rate of conduction, slow conduction. So technical term will be conduction velocity gets slowed. I am not using so many technical terms because nowadays most questions in exams are scenario based. It is enough if you understand the concept. So this finishes peripheral now, the commonest peripheral nerve disorder. Peripheral neuropathy is a very big entity. Okay, because I'll just tell you a small basic. We have Ganser's classification, I think. Classification of nerve fibers. We have A fibers, B fibers, C, right? A fibers will be A alpha, A beta, A gamma, A delta. A are thick fibers. They are thick because they are myelinated. A fibers are heavily myelinated. B fibers are thinly myelinated. C fibers are non-myelinated. Each fiber has a particular function. So A alpha fibers are the motor fibers. They carry afferent motor impulses to the muscle. A beta fibers are sensory. They carry proprioception. So motor and proprioception are very important. Their conduction has to be rapid. That's why A alpha has been designated for motor. A beta has been designated for proprioception. A gamma is also in motor, but they come in spindle fibers. That is in reflexes. Okay, to be very simple, they help in reflex physiology. A delta helps in pain. Since A fibers conduct pain fast, it is called as fast pain. Okay. So this is about A. B fibers are thinly myelinated. They help in other functions. So usually this comes in sympathetic nervous system. Autonomic nervous system will be thinly myelinated. C fibers are non-myelinated. So it is non-myelinated means there is very slow conduction. Okay, non-myelinated means very slow conduction. This is also helpful in pain and temperature. Pain comes in two places. There is fast pain mediated by A delta. There is slow pain mediated by the C fibers. So this is the Erlanger-Gasser classification of nerve fibers. These fibers are sensitive to different things. For example, A fibers are more affected by pressure. C fibers are most affected by anesthetic drugs. Okay. B drugs are mostly affected by metabolism, nutrition, and hypoxia. This is very, very important because large fibers, when given pressure, they easily get damaged. This is the reason for compressive neuropathies. Okay. Plus, only since A fibers are heavily myelinated, these are only damaged in demyelinating disorders like GBS, right? So that is why in GBS demyelination occurs of A alpha fibers. So we get weakness. A beta fibers are gone. So if you do a clinical examination, vibration and proprioception will be lost. The patient cannot usually appreciate that because of the weakness. So they complain of weakness, but on doing testing, proprioception will be lost in GBS. A gamma motor fibers are lost. That's why there is reduced reflexes. And fast pain will be affected. C fibers are easily affected by anesthetic drugs. That is why pain and temperature is easily lost on giving anesthesia. Very, very self-explanatory. The B fibers, that is sympathetic nervous system fibers or autonomic fibers, are affected by hypoxia or nutrition or metabolism. That is why in diseases like diabetes is basically a nutritional or metabolic disorder. There will be hypoxia which is occurring because of vasculopathies. So diabetes usually affects autonomic nervous system. The same diabetes also affects this one because C fibers are prone to anesthesia. Next one will be hypoxia. They cannot be affected by pressure because pressure is going to cause demyelination only. So C fibers are not affected by pressure, right? So diabetes will affect pain fibers first and autonomic fibers first. So this can lead us to understand how the different neuropathies can present by means of pathology. We discussed only one disease, which is a demyelinating type of neuropathy, which is occurring in acute inflammatory demyelinating polyneuropathy, AIDP of GBS or Miller-Fisher variant or Aman or Amsan. But in diabetes, a different pathology occurs where the large fibers are not affected. So there will not be motor fibers. That is why in diabetes we are going to get painful, peripheral, sensory predominant neuropathy. Of course, motor will be involved, but it is sensory predominant polyneuropathy. Okay. We'll give another example. What does B12 cause? B12 deficiency is going to cause problems with the myelinated fibers only. So B12 deficiency will present with motor weakness and proprioception loss, right? Alcohol again, it's a nutritional problem, toxic problem. So it is going to cause problem with the It will cause problems like seamless diabetes. B and C fibers are affected, so it will cause painful peripheral sensory predominant polyneuropathy. So likewise, there are so many causes like can cause neuropathy. There are some congenital neuropathies. Congenital neuropathy is simply called as Charcot-Marie-Tooth disease, right? So neuropathy is a very vast disease. Okay. At least remember Guillain-Barré syndrome, the cause is demyelination. But demyelination alone is not the cause for neuropathy. There can be toxic damage, there can be ischemic damage, there can be hypoxic damage. So likewise, there are so many causes, there are so many pathologies, right? But for examination point of view, GBS is more than enough. Okay, GBS, especially AADP variant, is more than enough to understand. Now we will discuss about neuromuscular junction disorders. So we finished about cerebrum, we finished brainstem. We didn't discuss much about spinal cord. We discussed about an important nerve disorder. Now we are going to discuss about neuromuscular junction disorders. So this is the normal neuromuscular junction. Neuromuscular junction has a presynaptic apparatus and a postsynaptic apparatus. What is the function of neuromuscular junction? See, this yellow one is the nerve ending. This nerve ending has many acetylcholine vesicles. There is something called as VGKC, voltage gated potassium channel. So when action potential comes to the nerve ending, what happens is this voltage gated potassium channels will open. There is something called voltage gated calcium channels also, CVGCC, right? So because of this impulse, what happens is voltage gated calcium channels will open. When voltage gated calcium channels open, calcium enters from the outside the cell into the neuromuscular junction. This calcium binds with the acetylcholine vesicles and causes acetylcholine to get released into the neuromuscular junction or the synaptic cleft. This acetylcholine now binds with acetylcholine receptors in the postsynaptic vesicle and it causes downstream signaling. MuSK is one of the protein which is helpful in downstream signaling. This acetylcholine helps in muscle contraction. This is what happens in the normal neuromuscular junction. There are so many proteins which help, like SNAR proteins. Right? We are not discussing that in detail. But what you must remember is there is something called voltage-gated calcium channel. We have acetylcholine receptor, like acetylcholine vesicle, acetylcholine receptor. Excess acetylcholine is destroyed by a enzyme called acetylcholine esterase. Okay, this is what happens in a normal neuromuscular junction. What is the disease called myasthenia gravis? Myasthenia gravis is also an autoimmune disease. In this autoimmune disease, what happens? There are autoantibodies which are produced against acetylcholine receptor. You can see in the image, there is acetylcholine receptor antibody which binds to the acetylcholine receptor and destroys the acetylcholine receptor. When acetylcholine receptor is destroyed, what happens? The acetylcholine in the synaptic cleft cannot bind to the acetylcholine receptor. So when acetylcholine does not bind to acetylcholine receptor, there is no downstream signaling, there is no contraction. So it leads to muscle weakness. Okay. But the thing is, when the muscle starts contracting, there may be some contraction because more acetylcholine will be there, more receptors will be there. So leaving off the damaged acetylcholine receptors, the existing acetylcholine receptors can accept the acetylcholine. But beyond a particular point, the more acetylcholine cannot be utilized more by the acetylcholine because acetylcholine receptors are few in number. So that is the reason why we get fatigability. So due to initial engagement of existing acetylcholine receptors, there may be muscle contraction, but as muscle contraction goes on, the remaining acetylcholine receptors cannot cooperate for muscle contraction. So that is the reason for fluctuating fatigable weakness. That is, after resting for some time, more acetylcholine can be released and contraction can resume. So there is fatigable fluctuating weakness in myasthenia gravis. So how will you test for myasthenia gravis now? I already told you the antibody which is there is acetylcholine receptor antibody. That can be tested in serum. 85% of the cases will be acetylcholine receptor positive. There is something called as seronegative myasthenia gravis, where acetylcholine receptor antibody will be negative. In that case, we can check for the other proteins, the downstream proteins, anti-MuSK, anti-SNAR, etc., anti-LRP4, etc. Now, how will you treat? Only few acetylcholine receptors are there, right? So, the existing acetylcholine receptors will be occupied by acetylcholine. The remaining acetylcholine is going to be damaged by the acetylcholinesterase. But we want more acetylcholine to engage as many acetylcholine receptors as possible. So we have to inhibit acetylcholinesterase. That is our aim. Can you link acetylcholinesterase inhibitor somewhere else? One, they are used in dementia. Second, our famous OPC poisoning itself is an acetylcholinesterase inhibitor. But here it is problematic because OPC, when it inhibits acetylcholinesterase, it increases acetylcholine to excessive high levels. Since acetylcholine receptors are more, it leads to organophosphorus coma or cholinergic crisis. But here it cannot occur because acetylcholine receptors are only few. So we are trying to increase acetylcholine levels in the synaptic cleft as much as possible to cause more of muscle contraction. The commonest drug which is used is pyridostigmine, which is oral drug. Neostigmine is also an acetylcholinesterase inhibitor, which is an IV drug, can be used in emergency. But when you give this cholinesterase in excess, what will happen? It can cause cholinergic crisis. So we have two crises in myasthenia. One is myasthenic crisis, which can be overcome by acetylcholinesterase inhibitor. When acetylcholinesterase inhibitor becomes to toxic levels, it causes cholinergic crisis. So both myasthenic crisis and cholinergic crisis cause weakness. So there are some tests to differentiate between these two types of weakness. So this is the history. So there will be muscle weakness, definitely. It will be a generalized muscle weakness. So there will be limb muscle weakness, eye muscle weakness, pharyngeal muscle weakness. Eye muscle weakness will cause ptosis. So that is the usual presenting symptom, drooping of eyelids towards the evening. We have dysarthria, dysphagia, pharyngeal myasthenia can be there. There is weakness. Fluctuation and fatigue is the one. That is more with repeated activity. It improves by rest. So how will you test that? In physical examination also, we have to test the fatigability. On repeated exercise, the weakness will worsen. And we can do ice pack test also. On keeping ice pack, acetylcholinesterase will be inhibited mechanically. So acetylcholine levels will improve. So lab testing we discussed. Anti-acetylcholine antibody, 85% of the cases will diagnose. If it is negative, we have to check for LRP4 and anti-MuSK. We have some mechanical test. One is repetitive nerve stimulation and next is single fiber EMG. So what we are going to check here, the decremental response. That is, we are going to do repetitive nerve stimulation. We know that on repetitive nerve stimulation, the muscle contraction reduces. That is called as decremental response. So RNS shows decremental response in this condition. SFEMG also shows, single fiber EMG shows this jittery factor. I told about the test to differentiate between myasthenic crisis and cholinergic crisis. It's a hydrophonium chloride test. It's not used nowadays. Ice pack test I discussed. On keeping ice pack, it mechanically inhibits cholinesterase. So acetylcholine levels increase. So ptosis improves. Right? Most of the time, myasthenia gravis is associated with thymoma. So, thymoma patients usually have myasthenia gravis. So these are the important points to remember. So when discussing about myasthenia gravis, we have an important DD. There are something called as congenital myasthenic syndromes. But you need not break your heads on congenital myasthenic syndromes. But one important DD for myasthenia gravis is Lambert-Eaton myasthenia syndrome. So what is this Lambert-Eaton myasthenia syndrome? Myasthenia gravis is due to anti-acetylcholine receptor antibody. Lambert-Eaton myasthenic syndrome is due to anti-VGCC antibody. So VGCC antibody is voltage gated calcium channel. So the channel through which calcium enters and causes extra granulation of the acetylcholine vesicles. So why myasthenia gravis occurs? Usually associated with thymoma, or I told it is a standalone autoimmune condition. Why does Lambert-Eaton myasthenic syndrome occurs? It is a paraneoplastic condition. Whenever you say paraneoplastic, one tumor should come in your mind, which is small cell carcinoma of the lung. Not only lung cancer, breast cancer, like many cancers, by paraneoplastic reaction, cause anti-VGCC antibody. So here there is fluctuating fatigable weakness causing decremental response in repetitive nerve stimulation. The opposite occurs here. There will be incremental response. Because on repeated stimulation, more acetylcholine can be released here. So it's opposite of myasthenia gravis. There will be incremental response in repetitive nerve stimulation. How will you treat here? Pyridostigmine initially. Since this is an autoimmune disease, we can use steroids. And in emergency, we have to give high dose steroids and we can give IVIG, plasmapheresis. Remember, IVIG or plasmapheresis can be done in any condition where autoimmune or immunoglobulins are high. So IVIG is the treatment of choice for AADP, right? So it is also the treatment of choice for myasthenic crisis. What about LEMS? Here again we are going to do plasmapheresis because we have to remove the excess VGCC antibodies. What mimics myasthenia gravis? I told you Guillain-Barré syndrome is an ascending paralysis. But if you see the chart, myasthenia gravis usually causes ptosis, diplopia, dysphagia, proximal limb weakness. So it's causing only a upper limb predominant type of weakness. So when it is severe only, it will cause descending. So myasthenia gravis is actually a type of descending paralysis. Snake bite is also a descending paralysis. So this myasthenia gravis is similar to cobra snake bite. Because cobra snake bite, this bite venom also damages the acetylcholine receptor. Likewise, Lambert-Eaton myasthenia syndrome or the incremental response is similar to crate venom. Because crate causes presynaptic, it damages the presynaptic voltage gated calcium channels, right? Now you can understand, since myasthenia gravis is a postsynaptic damage and it is similar to the snakebite coma, you can very well understand why neostigmine has a role to improve muscle weakness in cobra snakebite. We give atropine to counteract the increased acetylcholine. So atropine, neostigmine is one treatment option in cobra bite. Neostigmine is the therapeutic role, which is the cholinesterase inhibitor to increase acetylcholine to overcome the damaged acetylcholine receptor. We give atropine to counteract the excess acetylcholine, because excess acetylcholine causes cholinergic activity. Atropine is an anticholinergic. Whereas this neostigmine has no role in crate venom, because crate inhibits the presynaptic activity. There is no point in giving excess acetylcholine, because already acetylcholine is in excess. So there is no role of neostigmine. Right? So this is how you should associate. So when we read OPC poisoning, try to read about myasthenia gravis also. Try to read something about snake bite also. Okay. So now we'll discuss something about motor neuron disease. So I finished about now GBS we discussed. We finished about neuromuscular junction. Muscle we are not going to discuss. I'll just show the image later. So what is this motor neuron disease? See, whenever we say motor neuron, we have two motor neuron, upper motor neuron and lower motor neuron. Upper motor neuron is the neuron present in the cortex. Lower motor neuron is the neuron present in the spinal cord. We know very well that from cortex, the cortical neurons, their axons end in the spinal cord. After it ends, we have the alpha motor neurons or the spinal motor neurons, from where the next step starts. From their axons end in the neuromuscular junction. So we have upper motor neuron which begins from the cortex, lower motor neuron which begins from the spinal cord. So motor neuron disease is basically a problem with this. So motor neuron diseases can be pure upper motor neuron diseases. It could be pure lower motor neuron diseases. Now, in our UG days, we frequently discuss the difference between upper motor neuron and lower motor neuron. In upper motor neuron lesions, the lower motor fibers will overact, so there will be spasticity. In lower motor neurons, there will be flaccidity. What happens to the muscle bulk in upper motor neuron? The muscle bulk usually remains normal. In chronic diseases, there can be atrophy. We don't use the word wasting, we use the word atrophy. In lower motor neuron, there will be severe wasting. The bulk about the tone. Reflexes will be exaggerated in UMN lesions. Reflexes will be diminished in lower motor neuron lesions. They will be diminished or absent. Upper motor neuron, there is no fasciculation. Fasciculation is twitching of the muscles or muscle fibers. In lower motor neuron, there is fasciculation. Okay, so upper motor neuron usually will be spastic with exaggerated reflexes. Lower motor neuron will be a wasted muscle with diminished reflexes, but weakness will be present in both. When discussing this aspect, upper motor neuron lesion, I told reflexes are exaggerated. Exaggerated reflexes is of two types: spasticity and rigidity. Remember the mnemonic SPY. Spasticity occurs in pyramidal tract lesions. Pyramidal tract is nothing but the corticospinal tract. Rigidity occurs in, remember mnemonic SPY. Rigidity occurs in extrapyramidal tract lesions. Extrapyramidal tract lesion is nothing but the basal ganglia and its connections. So spasticity is actually hypertonia. It's a velocity dependent hypertonia. Increased tone. Whereas rigidity is a non-velocity dependent. So when you do examination, in every speed, if you do, the stiffness will be the same. It is non-velocity dependent hypertonia. Spasticity will usually affect one group of muscles more than the others. That is why in spasticity usually we get particular posturing. Usually upper limb is flexed at the elbow, lower limb is extended at the knee. So only one group of muscles are involved in spasticity. In rigidity, both the group of muscles are equally affected. That is group, I mean the gravity muscles and anti-gravity muscles. So both group of muscles are equally involved in rigidity, so there is no posturing. Spasticity will have weakness. So if there is a weakness with increased tone, it has to be spasticity. If there is no weakness, only increased tone, it is actually rigidity. So which disease causes all these things? Rigidity. It is Parkinsonism. So Parkinsonism is the extrapyramidal or basal ganglia lesion which causes rigidity. Spasticity occurs in pyramidal tract lesion. That is, example is CVA. When long-term CVA occurs, there will be spasticity. Now, this spasticity is given one very good name. It is called as clasp knife spasticity. This may be kept as a video. What is clasp knife? When we try to open a clasp knife, initially it will be difficult to pull the knife out. But once we pull, it comes out very easily. So likewise, imagine a person who is having a flexed upper limb. We try to extend the limb. It will be difficult initially. But once it starts to extend, it will be very easy to extend. So that is called clasp knife phenomenon, which occurs in spasticity. Whereas we have two phenomena in rigidity. One is lead pipe rigidity and cogwheel rigidity. What is lead pipe? Lead pipe is when you bend a lead pipe, in whichever direction we bend, it will be the same increased resistance. So that is lead pipe rigidity. Cogwheel is nothing but, so the cogwheel feel which we get, it is nothing but lead pipe rigidity, but there is a superadded tremor. So now I think you can relate to the Parkinsonism discussion which we had. There is bradykinesia because of reduced dopamine. And because of the basal ganglia lesion, there will be rigidity. So this is the second feature. And when it is associated with tremors, what we get is called cogwheel rigidity. So the fourth feature of Parkinsonism is postural instability. Right? So these are the four features of Parkinsonism. So just for a correlation here. So why we started this discussion is for motor neuron disease. So we have UMN lesion, LMN lesion. UMN features have spasticity, right? So the increased tone in UMN lesion is actually spasticity. Thus there is flaccidity here. Right? For that only I wanted to discuss. So predominant upper motor neuron involvement disease. So motor neuron diseases can involve predominantly UMN. It can involve predominantly LMN. There are some diseases which involve both UMN and LMN. So predominant UMN lesion is primary lateral sclerosis, if you try to remember. Predominant lower motor neuron lesion will be multimotor neuronopathy with conduction block, motor neuronopathy with paraproteinemia. And we have SMA, spinal muscular atrophy. There are some diseases. Remember, poliomyelitis is also a motor neuron disease because it affects the motor neurons of the spinal cord. Herpes zoster, coccygeal virus. So remember poliomyelitis, how they present, that is motor neuron disease. Upper plus lower motor neuron lesion is very, very important. It is amyotrophic lateral sclerosis. So why do these diseases occur? Again, these are neurodegenerative disorders only. So while you are revising these diseases, just remember the basic. Lower motor neuron lesions, how will they present? They will present with flaccidity, they will present with weakness, they will present with wasting. So if you think of spinal muscular atrophy, it's a predominant lower motor neuron type of motor neuron disease. So all those features will be present. If you think of primary lateral sclerosis, how does it present? It presents with weakness, but there will be spasticity, hypertonia, increased reflexes, etc. Upper and motor neuron lesions will be is the amyotrophic lateral sclerosis. So this is a peculiar disease because it is also a degenerative disease. I was telling you it is a TDP4-opathy. There will be deposition of TDP4. So the mechanism is there will be free radical injury to the motor neurons. So the pathway will be usually glutamate pathway or superoxide dismutase is one pathway which is involved. So you treat it by superoxide dismutase inhibitor, edaravone. There is another drug called Reluxol. So this is the drugs which are given for amyotrophic lateral sclerosis. But what I told you, ALS is nothing but UMN plus LMN type of motor neuron disease. So features of both will mixed. Like there will be wasting. Wasting is a feature of lower motor neuron. So a patient will be very much wasted. Of course, there will be weakness. Weakness is feature present in both UMN and LMN. But how will be the reflexes? Reflexes has to be diminished in LMN. But in UMN, it has to be increased, right? So in ALS, because of mixed UMN and LMN features, there will be wasting, but there will be exaggerated reflexes. This is how the clinical feature, typical clinical feature of ALS presents. I think these points are enough. So it may sound very theoretical because if you discuss about cardiology or endocrinology, most of the things we would have seen. But these neurodegenerative disorders, most of the neurology things may seem theoretical because we don't discuss it or see them often. Most of them are rare diseases. But try to remember some points if you had seen some patients, try to correlate. I have put this picture only to say about muscle dystrophies. So I was telling you muscle disorders can be either muscle dystrophies or myopathies. We are not going to discuss it here because it's a very vast discussion. So this picture may show some muscle dystrophies, like Duchenne's muscle dystrophy is a problem with dystrophin. Because muscle dystrophy is a milder variant of Duchenne's muscle dystrophy. You would have discussed Duchenne's muscle dystrophy in pediatrics. It is an X-linked recessive. So it affects only males. The cause of death is cardiac involvement. We have some other muscles like Limb-Girdle muscle dystrophy, Emery-Dreifuss muscle dystrophy. We have something called as myotonic dystrophy. Try to remember some names, but at least if you want to remember one, remember Duchenne's muscle dystrophy, which is X-linked recessive. It's a severe type of muscle dystrophy. There's a sign called as Gower sign, if you can remember. Usually they climb on themselves to stand from sitting position. It is due to dystrophin involvement. Death occurs usually at 20 years or 30 years due to cardiac involvement. So the last discussion of neurology will be about meningoencephalitis or meningitis plus encephalitis. Meningitis is infection of the meninges, which is covering of the brain. Usually it causes a triad. Fever, headache, neck stiffness. So you could remember the clinical signs of meningism. There will be neck stiffness. When you try to flex the neck, you can't flex it. That is called as neck stiffness. There is a sign called as Koenig sign. Maybe this can be portrayed as a video. Try to see that at least once. We have Brudzinski's sign. Brudzinski's sign is flexing the neck will cause flexion of the knees. Koenig sign is when you try to extend the flexed hip, when you try to extend the knee in a flexed hip, it will be difficult. So these are signs of meningism. Encephalitis is it's an infection of the brain tissue. So there will be in addition behavioral changes. Usually meningitis and encephalitis go together. Meningitis will cause fever, headache, neck stiffness, plus there will be behavioral changes in encephalitis. Usually encephalitis is associated with viral etiology. Meningitis is usually associated with bacterial etiology. Of course, everything can be there. If you think of viral encephalitis, we have herpes simplex. MRI image can be shown because herpes simplex encephalitis, the clinical presentation will be simple. Patient will be sudden, they will present with sudden fever and altered sensorium. Here the involvement, typical involvement of herpes simplex encephalitis will be the temporal lobe. Herpes zoster can involve. Japanese encephalitis can occur. Japanese encephalitis will typically involve the basal ganglia. Of course, even HIV can cause encephalitis, right? So, herpes simplex, at least remember, it's the most common viral encephalitis. Bacterial meningitis, we have many organisms. Streptococcus pneumoniae, Haemophilus influenzae, we have Neisseria meningitidis, also called as meningococcus. Meningococcal meningitis is important to remember because the classical syndrome is there, the Waterhouse-Friderichsen syndrome. The patient will be very sick. They will be having associated adrenal insufficiency. So they will be hypotensive. They will be in shock. They will be having hypoglycemia, etc. H influenza usually occurs in the 1 to 3 years of age group. Streptococcus pneumoniae usually occurs in adult age group. We have something called as Listeria monocytogenes. Listeria monocytogenes typically causes meningitis beyond 50 years of age. So try to remember the organisms. So even if you don't remember the organisms, this is very important. How to differentiate between viral meningitis, bacterial meningitis, TB meningitis and cryptococcular fungal meningitis. So it is definitely by CSF. So when you do a CSF analysis, first thing what you see is the pressure. So in bacterial meningitis, the opening pressure, CSF opening pressure will be very high. Yes, why it is high? Because white blood cell is high, neutrophils are more, the protein count is high in the range of 100 to 500. Since neutrophils are more, cells are more, the glucose will be low, right? So increased opening pressure, high white cell count, mostly neutrophils with high protein and low glucose is bacterial. Now we will see viral and tuberculous. Tuberculous is also a bacteria. So since it is a bacteria, glucose will be low, right? Because the bacteria consumes glucose. It is a bacteria, so proteins will still be high, right? So white blood cell count also will be high. Even though it is not in the range of bacterial, white blood cell count will be high. What differentiate bacterial from tuberculosis? Bacterial meningitis will have neutrophilic leukocytosis. Tuberculosis will have lymphocytic. So increased opening pressure, high neutrophil, high protein and low glucose is bacterial. High white cell count, lymphocytic predominant, high protein and low glucose is tubercular. Viral is not a living organism, so it cannot consume glucose. So Viral also will cause a lymphocytic infiltration. Low protein, because it's not a living organism, it cannot produce protein. So viral will have low protein. Viral is not a living organism, so it does not consume glucose. So glucose will be normal. CSF glucose will be normal. And white blood cell count also will be mildly elevated. So mildly elevated white cell count with lymphocytes, normal glucose, low protein is viral. Cryptococcus is fungus. So how will you define fungal? Fungal is also mononuclear. But fungus is an organism, right? So it consumes glucose. So low glucose, high protein, mononuclear, and moderate cells will be fungal. But fungal can be easily confused with tubercular, right? So when will you think of fungal then? Fungal meningitis usually occurs in people who are very severely immunocompromised, like in HIV. So if a background of a HIV patient is given and history of meningitis or encephalitis is given, CSF is given like a tuberculous meningitis, still TB is common, but fungal is also common. Now how will you diagnose that? If a cryptococcal meningitis, we have a special test, right? India ink stain. So CSF is not the final diagnosis. This will give only a clue. So to diagnose fungal, we can send India ink stain. To diagnose tubercular, we can send CB-NAT, we can send CSF ADA. ADA is a protein which is elevated in TB. We can do acid-fast base staining, Zeal-Nielsen staining can be done. For bacteria, we can do a culture. We can do a culture sensitivity. And for viral, we can send viral PCR. PCR testing can be done to identify which type of virus. And important aspect in treatment is we have to give antibiotics, of course. Antivirals can be given. Most important thing in bacterial meningitis, we have to give dexamethasone, steroid. So steroids has to be started first before giving antibiotics. Because on giving antibiotics, the bacteria will break down. It releases breakdown products which will cause so much of brain reactions. So dexamethasone has to be given before starting antibiotic in meningitis. Okay, I think these things are enough.